Welcome everybody. This is our next webinar, and today we will talk about the first part of this webinar will be antiviral medications. Okay, antiviral drugs. I want just to let you know that we are going to do remarks about NCLEX format questions, and we mostly we don't going to talk about the pathophysiology of the disease or the major information because this is pharmacology. So I'm going to make some summary and some very briefly annotations about the pathology that we are going to see most commonly for this part of the course. So let's start. The first slide is going to be we call antivirals. Let me see if I can pass the other. Okay. Okay, so this is the mnemonic we are going to use. Very simple. Is 1, 2, 3, 4, 5, 6, 7. Is about reach. We already talked about this in class. We are going to repeat it, and we are going to be very brief. So the number one pathology we will talk is the respiratory syncytial virus. We have I is going to be related to influenza, Cytomegalovirus. We are going to talk about the hepatitis B, hepatitis C, herpes, and the HIV. So those are the high yield for NCLEX. So please, let's start. So number one, we have here the respiratory syncytial virus. It mostly happen in very young people, about 2 years old. And the signs and symptoms are going to be between simple cold signs or they can reach into pneumonia. Pneumonia is not only caused by bacteria, it can be caused by fungus, it can be caused by viruses. So the RSV, respiratory syncytial virus, mostly is going to affect people or children who are, for example, premature or they are going to have some malnourishment from early stages. So that is about the RSV. And we are going to see, I put here some nursing care plans. So it's about an effective airway clearance or an effective breathing pattern. So that is mostly what happened in the respiratory diseases or infections. So RSV, we will going to use antivirals. The next slide. Okay, so the next one is, first of all, R, influenza virus. Now is I. Influenza virus, we have two types of influenza virus, A and B, mostly that is very contagious virus that mostly will affect young people, infants, less than 1 year, and elderly people. So there is very contagious. The incubation is about 2 days, febrile syndrome, sore throat, and they can lead into respiratory failure and death. So influenza versus cold. Influenza mostly is going to have signs and symptoms of dry cough and sore throat pain. Meantime, cold is going to be, simple cold is going to be more, have more secretion and sneezing, more nasal secretion. Now we will talk about cytomegalovirus. Cytomegalovirus is the family of the herpes. And the herpes, we have many other diseases. We are going to talk a little bit about that can be related to hepatitis for herpes virus. So for example, I will tell you now, herpes type 1 is the herpes of the mouth, oral herpes. Herpes type 2 is going to be for genital herpes. Herpes type 3, herpes virus type 3 is the varicella zoster, that in childhood is called the chicken pox. But when it get dormant, the virus, and in adults it's going to give you the shingles, that is the herpes zoster. The herpes virus type 4 is due to mononucleosis, is the Epstein-Barr virus. And the herpes type 5, that is the type we're talking right now, is the cytomegalovirus. So herpes is everywhere. Herpes, they have different presentations. And the herpes type 8 is sarcoma kaposi, that is one of the viral infections that happen in HIV. So let's focus now in the cytomegalovirus. We have this cytomegalovirus can be transmitted by kiss or droplets of or some saliva, and what happens in pregnant. So that is very important in pregnant. In pregnant can get the cytomegalovirus, and the cytomegalovirus can produce deafness, blindness, and mental retardation in the fetus. So what we need to prevent, we need to avoid contact with saliva with kids. So the kids are mostly the one who has this cytomegalovirus. Do we know that they have cytomegalovirus? Mostly not, because they signs and symptoms are going to be similar as a simple cold. Okay, so in cytomegalovirus, related to this lecture, we need to remember the cytomegalovirus retinitis. This is an inflammation of the retina and can lead into blindness. Cytomegalovirus retinitis, and that is something of your interventions, or mostly of your assessment, sorry, of the patient that you need to be aware all the time. Cytomegalovirus, we are going to have some antiviral medication. So we have the herpes simplex, that is the herpes type 1. And you see here we have the outbreaks here. That is the varicella, this is the herpes on the oral herpes. And here we have the genitalia. So there is different type of herpes. And herpes is one that we are going to use antivirals. Okay, so hepatitis B and C. Hepatitis B and C, we have antivirals too that control the number of viruses in blood. Hepatitis B and hepatitis C, they have actually some number of patients are going to have they are going to be carriers of the virus. So some of them are going to heal. Hepatitis B, 90% heal, 10% are carriers. Hepatitis C, 90% are carriers, and 10% are they are going to heal. So there's a big difference of actually the virulence of this virus. So we are going to use antiviral. So tell me one thing: do you think we are going to cure the hepatitis C? We are going to cure the cytomegalovirus or hepatitis B or herpes zoster? Absolutely no. Antiviral, what they are going to do is to diminish the signs and symptoms and to make shorter the period of the disease. We have HIV. We have what is doing the HIV with the antivirals are going to inhibit the viral replication. So it's not going to cure for the HIV, but it's going to control the viral amount in blood. So just to give you an example, we have, this is 2012, we have HIV in the United States, we have about 1,200,000. And in some calculations, in San Mateo County, we will have about 600 people having HIV and 25 new cases every year. So here the dark areas are the most common, or the most high incidence of this problem. All right, so let's start talking about antiviral drugs. And just remember, reach the word, right? So we have the RSV, we have I, influenza virus, we have C, the cytomegalovirus, we have H, we have the herpes, hepatitis B, hepatitis C, and the other H is the HIV. And that is what we are going to do today. The frame, we are going to start talking about antivirals. All right, so what is antiviral? We already been mentioning is destroy or suppress the virus or inhibit the ability of the virus to replicate. So stop the replication. So we are not going to get rid of the virus completely at all. So we are going to control the signs and symptoms and delay the the progression of the disease. Give me a second. Okay, so the antivirals, what they're doing is to kill viral infected cells and healthy cells. So that is what is doing the antivirals. All right, so in general, antivirals side effects, and that is what you need to remember always. That is going to be for the general signs and symptoms, side effects, sorry, of the antiviral. We have liver, kidney, hepatotoxicity, nephrotoxicity. They are going to produce photosensitivity. So what are your nursing considerations about that? We have the hepatotoxicity. We are going to see the LFTs, nephrotoxicity, Chem7, photosensitivity. We'll see the exposure to the sun. So there is nursing considerations about that. Then we have the long-term side effects, and this is extremely important too for a question for NCLEX. We are going to see that you need to remember the mnemonic oil that is for long-term side effects. That is the osteodystrophy. Please, we just remember that osteodystrophy can include, for example, the osteoporosis. What is osteoporosis? Is the demineralization of the bone. So that is one of the side effects in the long run of antivirals. Insulin resistance, so they can have signs and symptoms of diabetes mellitus. And lipodystrophy, that are going to produce the appearance of the patient are going to change. So definitely there are going to be some nursing considerations about the lipodystrophy. So for example, one side of the neck is going to be bigger than the other because there is some changes of the amount of fat that you have in your body, or for example, in the abdomen or in the back or in the neck. So that is going to be some problems that the patient are going to address, and probably they are going to have some nursing considerations. All right, so here we have antivirals, encourage fluids. It's not a cure, but they're going to relieve signs and symptoms. We have just put in your mind all the rich mnemonic that we was mentioning. And in general, what we are going to provide is the probenecid. Probenecid is, in addition of the antivirals, is a medication who is going to decrease the nephrotoxicity of the drug. Okay, especially the cidofovir, that is antiviral. But in general, please just remember, probenecid, in many cases they are going to be used with antivirals, especially when it's in the long-term treatment for antivirals. Okay, all right. So one thing is, from all the viruses that we was mentioning, the only one who is going to last permanently is the HIV, because the RSV, the herpes, the hepatitis C is going to last for forever if there's a carrier of the patient. But just remember, all the antivirals who are going to be used for about 1 year or more, they are going to have these oils side effects. Osteodystrophy, remember again, please, open eyes, open ears, the osteoporosis, insulin resistance, and lipodystrophy. Probenecid is going to decrease the nephrotoxicity. Remember, we was talking about the main side effects of antivirals, hepato, nephro, and photosensitivity. So in this case, probenecid is going to decrease the nephrotoxicity of this drug. So let's keep going. We have all the summary of the pathology we are going to see. We have RSV. You know which population is most commonly happening or incidence of this problem. We just remember the ribavirin, R and R, ribavirin. Influenza, we have the Saro. Saro is the zanamivir or seltamavir, the amantadine and the rimantadine. So Saro. Saro is the mnemonic to remember all the drugs for respiratory problems. In this case, we have influenza, Relenza, and the Tamiflu. All right. So in addition to that, remember that these drugs need to be, there is two things. we have the vaccine and we have the treatment. The vaccine to prevent the antivirals is to treat. Okay, to treat means not to cure. In this case, they are going to. That means the signs and symptoms go down or diminish, and the length of the disease is going to be shorter. Okay, so cytomegalovirus is the ganciclovir. So as I mentioned, please just remember megalovirus, big. They are going to have. It's called megalovirus because they make the cells here, the nucleus make it appears bigger. So that's why it's coming this name. And this guy is a very bad guy. Very bad guy is like a gangster. That's just to remember. Ganciclovir, cytomegalovirus, ganciclovir. Open eyes, open ears with this cytomegalovirus. Okay. Just remember pregnancy, fetal deformations, prevention. The mother cannot be in contact with kids because kids they have this cytomegalovirus, and the kids appears like they have a cold in some cases. In other cases, do not have signs and symptoms. So in order to transmit, just prevent pregnant women just to be away from kids that are sick at that early, about 6 years old, 7 years old. All right, so herpes, we have aciclovir. This is very famous. It's the Sovirac, the commercial name, the aciclovir. Okay, so we have hepatitis B, is the lamivudine. Hepatitis C, that is similar to the RSV, the ribavirin, and the antiretroviral, that is the sidobudin. This is a must. Sidobudin is a must, should be given in patients with HIV. We are going to talk about that now. So now, talking about the ribavirin, ribavirin is going to be used for the RSV, and we have the aerosol form, and you can tell this RSV mostly is happening in very young population, especially after born neonates or kids that are born from premature delivery. So that is going to be used. What is the path? What is the route we are going to use? This is the aerosol form, the ribavirin. Okay. All right. So we have the that is the RSV. So let's talk about the influenza virus. Influenza virus, they are going, this, especially the oseltamivir, is the one who is going to be given for these patients. So we have side effects, orthostatic hypotension, influenza virus treatment, orthostatic hypotension. So what is your nursing consideration here? Besides the how to move the patient, you need to take at least twice the blood pressure a day. Okay. So we will not give aspirin or acetaminophen. So just remember, you already know that kids that are less than 18 years old, don't, if they have fever and suspect from some virus, don't give aspirin, okay, acetaminophen neither. Why? Because they produce what we call the Reye syndrome, Reye syndrome. What is the Reye syndrome? Okay, what Reye syndrome is actually an inflammation of is going to be an inflammation of the brain. So that's why it's going to be called the Reye syndrome. We call Reye syndrome. Reye syndrome. Okay, is R-E-Y-E. R-E-Y-E, Reye syndrome. You can actually search that or Google that later. Okay, so we have these drugs. When you have the signs and symptoms of influenza, started maximum after 2 days, to start the signs and symptoms. Why? Because after that time, the medication is not going to be useful. Zanamivir and oseltamivir have the fewer side effects. So in this slide, what I want you to remember is what I just mentioned is orthostatic hypotension, influenza virus treatment, and no aspirin acetaminophen in younger of 18 years old. Okay, so we have the ganciclovir. The ganciclovir, let me do something here. Okay, the ganciclovir is the bad guy, as we mentioned, just to remember, is the for cytomegalovirus. We already explained what is cytomegalovirus very briefly, and what we need to remember here is the bone marrow suppression. Open eyes here, open ears, we have the cytomegalovirus ganciclovir BMS. BMS is the bone marrow suppression. So if you have bone marrow suppression, you have your nursing considerations. Low red blood cell could be anemia, low platelets could be bleeding, low white cells, a risk for infection. So what we need to do is, for example, check blood count, CBCs. Okay, so another thing that we need to remember we was talking about cytomegalovirus retinitis. So that is something that you need to be aware, that is one of the, not the side effect of the medication, but is one of the complications of the disease itself. So eye problems, abnormal vision, any blurred vision or any abnormality or the patient can say or refer, need to be reported to the doctor immediately. Okay, so again, ganciclovir, as other antivirals, are going to have hepatotoxicity, nephrotoxicity, is going to be photosensitivity. Okay, okay, so let's keep going. So we have the aciclovir. The aciclovir is one of the things that I want you to remember always, is the aciclovir in cream, could be IV too, but the one who is giving in cream with herpes, right? Herpes could be any the herpes of genitalia or the mouth or herpes, can actually produce at the time you apply, produce burning. It's going to be burned, and that is what you need to tell the patient. Always being asked that. Okay, so the patient they need to learn how to cover the lesions using gloves in order not to prevent or to spread the lesions, and we are going to have a thick layer or a thin layer of aciclovir. We are going to have a thin layer of aciclovir. Why? Because it's burning, right? It's going to burn. If you put a thin layer, it's not going to be the same as you put a thick layer, because the burning is going to be more important. All right, so we have aciclovir do not cure herpes and will not prevent transmission of the disease to others or recurrence. So do not prevent the transmission. So always you need to have your gloves, your aseptic area, not to share medication from one patient to another patient, or to keep the medication for later. So you need to use all the medication that is being prescribed. So antivirals in general shortens the episode of the process. All right, so don't share treatment. As I mentioned, we have transient burning may occur topical application with aciclovir, and another high yield for this webinar is the IV aciclovir. IV aciclovir should be taken in slow infusions. Why? Because they can produce thrombophlebitis, okay? This thrombophlebitis is the inflammation of the vein and can produce totally closure of the vein, and that cannot be used. You need to use another vein in that case. Without, I'm not mentioning the pain and actually the burning, especially the pain. The patient is going to complain about pain because of this. So a slow infusion. Lamivudine, the only thing I want you to remember here is we talk about chronic hepatitis B. When I said chronic hepatitis B, is because the patient is a carrier. You remember, from 100% of patients of hepatitis, 90% will heal and 10% are going to be carriers. So they are going to have hepatitis for the rest of their life. And for this, they need to have some lab tests to check the antibodies to verify how is the viremia, or means the amount of virus in blood. And the lamivudine is producing lactic acidosis. The way that it happened is unknown yet. So there is different things that can explain that, but this is not the purpose of this class. So lactic acidosis is going to be one of the side effects for Remember, hepatitis B treatment, lamivudine, and produce lactic acidosis. All right, so let's talk about the antiretroviral medication, and let's put at the start of this group is the sidobudine. Sidobudine. So, and sidobudine cannot be given alone. Of course not. Why? Because they can produce resistance to the virus. The virus is pleomorphic. It's going to change many ways, and they are going to adapt, and they are going to mutate, and they are going to be resistant. So that's why we give more than one at the same time. We don't try to stop the virus replication in one way. We're trying to do it in three ways, different ways. So that is actually more effective and reduce the number of cases of resistance to the drugs. Okay, all right. So giving only one drug alone is contraindicated. So please pay attention to that. All right, so let's keep going. So one of the keywords of the antiretroviral treatment, okay, antiretroviral treatment is about the adherence. Adherence to the medication. So how responsible is the patient taking the medication? Okay, so it's important not to miss even one dose a day. It's important not to miss a dose because that can allow the virus to mutate and produce resistance. Another thing that sidobudine is the bone marrow suppression. Bone marrow suppression. So I want just to add some let me write down here, please. For example, I want just you to remember this word. It's called art. Art. Art is the general way to describe that is the antiretroviral therapy. Antiretroviral therapy. Art. Art is the antiretroviral therapy. Antiretroviral therapy. Okay, so that is about. Sorry. I almost canceled the webinar. Oh my God. Okay. So let's keep going. All right. So, do we give sidobudine to a person who is pregnant, or a woman pregnant? Actually, no. Oh, actually, yes. Sorry. They are going to prevent the transmission of the virus of the infant and protect the mother itself, and prevent the transmission of the virus during the delivery. So 30% of the newborns are going to have the virus during the delivery time, vaginal delivery. Okay, so atazanavir, that is one of the other three medications that we are going to, together with sidobudine, are going to be for long run. 1 or 2 years, you start to have the lipodystrophy. So it's the redistribution of fat stores, and that is going to produce some the appearance of the patient. So self-esteem is going to be hurt by this. So the patients are going to have some psychological support and some surgical sometimes procedures. All right, so let me close this first, just a moment. Okay. Didanosine is didanosine is going to be another drug for HIV, and didanosine is in addition can lead into pancreatitis. Didanosine. So far what we have for antiretroviral is going to be that, first of all, the adherence. Second, you need to keep in mind your bone marrow suppression. So bone marrow suppression, risk for infection, risk for bleeding, risk for anemia, right? So bone marrow suppression, we have mother can receive the treatment, okay? Long run produce oil, remember oil, osteodystrophy, insulin resistance, and remarkable here is the lipodystrophy, oil, OIL, right? The adenosine is another anti-HIV virus that can produce pancreatitis. And the last one is going to be the stabudine. That stabudine can produce peripheral neuropathy and can lead into gait. Okay, so that is about, let's one more time, very short. We have adherence. So HIV adherence, very important, patient education, right? Bone marrow suppression, pregnancy, pancreatitis. So those are, and gait. So those are the most common things that we need just to remember and make a note, make a summary, and try to remember those. All right, so again, we have the REACH, RSV, the influenza virus, the cytomegalovirus, the herpes, hepatitis B, C, and the HIV. So those are the main medications, main things that we are going to use now. So ribavirin, okay, we have cytomegalovirus, the ganciclovir, we have the aciclovir for herpes, lamivudine in hepatitis B, ribavirin, similar as RSV for hepatitis C, and the HIV is the what we just mentioned, the sidobudin. And talking about the sidobudin, we was talking about 3 drugs of HIV, and I'm going to just write it down there here, just to make it easy to remember. So we have here, let me see, let me write down here. We have sidobudin. I don't know what happened with the pen. Okay, I'm going to write it down here. Sidobudin. Second, we have the atanavir. So my pen is not working properly. The didanosine. And the other one, the stabudin. Okay? Atanavir. So here we have the BMS in the sidobudin. Atanavir is going to be the lipodystrophy. The didanosine is going to be the pancreatitis. And the stabudin is going to produce the peripheral neuropathy, that is the gait, going to lead into gait. Okay, all right, so that is about that. So let's keep going with the next part of the webinar is about talking about the antifungals. All right, so let me close this first. Okay. All right, antifungal drugs. Antifungal drugs, we are going to talk about the general things, and then we are going to go specifically on what we are going to see in Ankles. So we have amphotericin B. It's very important, amphotericin B. Amphotericin B is going to be for systemic fungal infections. Remember, fungal infections can be divided in systemic, so that means can affect any of the systems of the body, and the superficial. Superficial, for example, we have the fungus on the skin, fungus on the nails, that is called onychomycosis. The nystatin is actually superficial. The azoles is the miconazole, ketonazole, itraconazole, fluconazole. So all azoles are going to be the same group. They can be used for systemic and some of them for superficial. Okay. All right. So we are going to talk about each of them in the next few moments. So one thing I want you to remember here is the azoles. These azoles are going to have increase of the anticoagulant effect. So what are your nursing considerations? You need to keep thinking about your PT, your INR exam, etc. Right? All right, so antifungals, general general side effects. Remember, in virals, we have antivirals, we have is going to be hepatotoxic, nephrotoxic, and photosensitivity. Here in antifungals, it's going to be hepatotoxicity. It's going to be nephrotoxicity always, but more remarkable is hepatotoxicity, just considering both sides. Antivirals, antifungals, hepato and nephrotoxicity. And rash. Rash is some redness appearing in parts of the body, and that is the decoloration of the skin, correct? All right, so, and that is temporal. Okay, so let's keep going. One thing that antifungals can lead is the leukopenia. Leukopenia. That is similar as, remember, the pseudobudin. The pseudobudin is the one who pseudobudin antiviral is the responsible for BMS, bone marrow suppression. Here, antifungals in general, all of them can lead into leukopenia. Obviously, the one who are taken by IV or for PO in long periods of time, they can have more risk for this. The ointments, they can have that, but it's very low risk. All right, so here we have antifungals given with food. So antifungals are produce increase of gastric acid. So that's why you need to give with food. The bioavailability is not going to be affected given with food. So it's okay to give with food. That decrease the effect of gastritis. Okay. We have a good oral hygiene because when a person is having some fungus, some fungal infection, most of the people who are having his immune system very low because these microorganisms mostly are opportunistic infection, produce opportunistic infections. Okay. CBC, why CBC? Why CBC? Because in the previous slide we was talking about that that can produce leukopenia, right? Leukopenia, what is leukopenia? Low levels of white cells, leuco, white, pinia, blood, right? So we have CBC. Liver and renal functions, again, we was talking about the pathway, the nephrotoxicity, right? And this is going to be as a baseline, okay? A baseline, because you need to have a baseline in order to compare what is, or to monitor what is the effectiveness of the medication after you give the medication to the patient, right? Allergies, all right? So it's some possible contraindications. And your EKG. EKG, we will see that there is some medications that can, antifungals that cannot go with antiarrhythmics, because they produce more arrhythmias, and we will see that now. Okay, so assess for other medications using prescribed OTC to avoid drug interaction. What is the main thing? One of the most common is the azoles, the ketoconazole, the miconazole, all the azoles. And these azoles can interact with the warfarin, right, with anticoagulants. And you already know from previous lecture that we have the few garlic. So those are going to interact with the anticoagulants, right? Ginseng, ginger, few, we have garlic, right? So those are going to interact with the anticoagulants, so that is going to be over-the-counter medications that you need to assess and you need to document. All right, so we have here that antifungals, one of the most common is vaginal fungal infection. And that is when you, patient education, you need to tell the patient not to have any sexual intercourse until they finish the treatment. Otherwise, it's going to be transmitted and it's not going to heal, so it's going to be getting worse. So another way to another fungal infection is thrush, for example. Thrush, we have a Candida albicans, Candida albicans. So we have the lozenges. Lozenges are a presentation where you put the tablet in your mouth and that's going to be dissolved bit by bit. We don't need to crush it or chew it because the purpose is to release slowly the medication from the candy, let's call it, or the candy, it's a type of candy called lozenges with medication there. that is going to release bit by bit and is going to just wash the air, the oral cavity, and that is going to be how this is going to be. So we don't need to crush it or pass because it's not a way to take it. Another thing, so we was talking about general antifungals, right? So if we go back here, we was talking about amphotericin B, okay, amphotericin B. This amphotericin B is a very important medication for systemic fungal infections. I'm not going to talk about histoplasmosis capsulatum. I'm not going to talk about other type of fungal infections like pyromycosis or etc. So, but definitely when you have, for example, aspergillosis is a systemic fungal infection too, and we will see the treatment for that in a few. All right, so let's focus on amphotericin B. Is for systemic life-threatening fungal infections. We have here, this is high yield for NCLEX, so please pay attention to this. Amphotericin B in a slow infusion. We need to have a slow infusion because it can produce thrombophlebitis, literally. So what does that mean? If you put too fast, the patient starts to have some itchiness on the area of injection. Then it starts to be swollen and swell edema, burning after that. So itchy and then burning, very bad. So itchy because it's going to distend the skin and then it's going to turn into pain. Okay, itchiness is pain itself, but at the beginning of that pain is the sensation is feels like an itchy. So in that case, you need to just stop the medication and probably you need to give it no less than 1 hour. So you need to give it more than 1 hour. So that's why we use infusion pumps in order to control the time of infusion. They are going to literally almost burning. It's like caustic. It's like making the vein inflame, and they are going to shrink at the end. So that vein we cannot be used anymore. Don't mix with any antibiotic because they are precipitating. Pre-medication, so the amphotericin side effects are going to be nauseous, vomiting, some elevation of temperature. Amphotericin can elevate the temperature. So apparently some fever, but it's actually the side effect of the amphotericin B. So for that, if we know already the problem that is going to happen, we can pre-medicate the patient, giving aspirin or Tylenol, diphenhydramine, that is the Benadryl, and steroids if that is required, right? We have stop infusion in tingling in extremities. So any changes on the any part of the body who has tingling, especially in the extremities, we need to check for signs of phlebitis or infiltrations. You need to stop the medication. You need to stop. Okay, so there is two types of presentations of amphotericin B. Very high yield for NCLEX is the amphotericin B and the lipid amphotericin B. Lipid amphotericin B is it's not that new, it's about 10, 15 years, and that is going to have less side effect of than the amphotericin B. The name is amphotericin B, and the other name is lipid amphotericin B. So which one you prefer? So that is you can tell by the side effects. Side effects on amphotericin B: blood discrashes, malaise, fever, chills, headache, nausea, vomiting. So those are the side effects that amphotericin is going to show during the administration or after the administration of the amphotericin B. So what we need to do is just to give these antihistaminics, painkillers, etc. Right? Okay, so one thing that we must remember about amphotericin B is the hypokalemia. So for this, I have this mnemonic that is going to help you very much. So please, here, big star here. So, or pyramid, whatever you want to call. So we have amphotericin B. A, no mix with antibiotics. M, malaise. So that's why we are going to give some pre-medication. Pre-medication, P, HO. So this in O, there is nothing here. HO, hypokalemia. Hypokalemia. Okay, hypokalemia. Hypokalemia is an electrolyte imbalance, and what they are going to, any imbalance could be high or low potassium, it could produce arrhythmias, cardiac arrest. So be careful with that. Be careful. This is very important. The hypokalemia in the amphotericin B. So just about that. Okay. So time is. Oh, by the way, you need to know the values of potassium. Okay, 3.5 to 5. So if they give you some lab tests or they requesting what could be a low or high level or some of the potassium in amphotericin B, you know that you know how to answer that, right? So you need to know the range, the normal value of potassium. Infiltration, look for infiltration and nephrotoxicity. Nephrotoxicity, again, you need to know your Chem7, right? All your kidney functions. Blood dyscrasias, and B means lipid amphotericin B that is having less side effects. Okay, so let's keep going. We are talking about fluconazole. Fluconazole is a systemic and is considered to use as a for vaginal yeast. Okay, and what is important about the fluconazole? The diflucan, they can be given as a single dose. Single dose. Fluconazole. Fluconazole. Okay, fluconazole. Nursing considerations can be IV oral routes, signs, side effects, nausea and vomiting, rash, hepatotoxicity. Again, right? So we don't need to memorize all this stuff because the general thing about antifungals is that they can produce rash, they can produce nephrotoxicity, they can produce some hepatotoxicity too, and leukopenia, especially with a systemic antifungal. We have the voriconazole, so you already know that where group belongs to, the azole, and this guy, the azoles, so fluconazole or voriconazole, are going to be used, are going to interact with or increase the activity of the warfarin, okay? But in addition to that, the voriconazole can produce arrhythmias, These arrhythmias, these need to be reported, okay? Voriconazole, fluconazole, voriconazole, okay? So if you, in this case, fluconazole and voriconazole, you add the hepato, the nephro, and the rash. And the considerations of fluconazole can be given for one dose, voriconazole, arrhythmias, so be careful with arrhythmias. Can be used as a caspofungin, is another drug of antifungal we are going to see, can be used for aspergillosis too. Aspergillosis, okay? Antifungal flucytosine is used for, is another group, is not the azole group, is the flucytosine, is for Candida septicemia. Candida albicans septicemia means that the fungus is going to spread out in any of the systems. The favorite for these Candida albicans are going to be the lungs. The lungs. Second is going to be the kidneys. Third is going to be the brain. So those are actually very life-threatening problems. Especially you see that in patients who has some immune suppression like HIV. Okay, so again, the side effects are going to be nausea, vomiting, diarrhea. That is the three bigs from all medications, and you need to keep hematologic. Why hematologic? We was mentioned at the beginning that can produce leukopenia, especially when you are doing systemic medication. When you're doing systemic medication, those are the big things that we need to think about. The hematologic, that means leukopenia. So what is your risk? Risk for infection, for example. Rash, right? Rash, the hepatotoxicity, nephrotoxicity, the same thing that we was talking from the very beginning about antifungals. We have antifungal agents. Again, we have the caspofungin. This is one of the latest and very effective medication, caspofungin, used for aspergillosis. So what is aspergillosis? Aspergillosis is a fungus. Aspergillosis is going to have actually three different forms. So it could be fungal balls that mostly are going to be in the lungs. Another could be allergic. Another one that probably you are going to see most commonly is invasive aspergillosis that we have that mostly is happening in HIV patients. HIV, caspofungin. So NCLEX, they love to ask you about this caspofungin aspergillosis. What is aspergillosis? A fungus. A fungus. Whereas these fungus are opportunistic fungal, opportunistic microorganism. All right, so let's keep going. We finished with what? With deep with systemic fungal infection. Let's talk about the superficial mycosis. Superficial mycosis, we have the griseofulvine, is the ringworms. Okay, the ringworms. We have the onychomycosis in this side. Onychomycosis is the presence of fungus on the nails. Okay, so we will have again the same side effect, nausea, vomiting. That is our topical. So the side effects are not going to be as severe or often as the systemic, right? As the systemic antifungals. So they can have rash, they can have they can have hepatotoxicity, nephrotoxicity. They can have actually some neutropenia. And neutropenia means low white cells. In this case, the neutrophils are low. And for this slide, what you need to remember is the ringworms, griseofulvine, ringworms, ringworms. And the word the onychomycosis. The on is the dermatophytes, but is called in general the process is called onychomycosis. Onychomycosis. So that is the treatment for this. It should be superficial. I mean some creams, ointments, and or PO. So for example, we can give griseofulvine, that is in PO presentation. Terbutaline is going to be in cream presentation. So both can actually make shorter the treatment and more successful. All right, so here we have, again, we was talking about the azoles, right? Azoles is going to be systemic and can be superficial mycosis. But if we was talking about, for example, the voriconazole, right? The fluconazole, those are for systemic, and we already talked about the for vaginal yeast and we are going to see the voriconazole can be used for aspergillosis too. But in this case, we are talking about the superficial, and this is the ketoconazole, the clotrimazole. This is actually a very common, the clotrimazole. So nausea, vomiting, hepatotoxicity, rash again, right? So the azoles are going to increase the warfarin effect. We mentioned that already, right? So you need to just make a shortcut, make what is the main branches of side effects, make a summary in a paper, and make a small algorithm, and that is going to help you to remember all this. All right, so another thing that I want to remember is the administer with food, okay, because it can produce gastritis. No alcohol, please. Alcohol are going to increase is going to decrease the effectiveness of the medication, number one, and second is going to increase the toxic levels. So it's not going to be eliminated. It's the liver prefer metabolites first alcohol than any other things because that is going to be easier for the liver to metabolize. Okay. All right. So nystatin. In the nystatin, we have thrush, right? Thrush is the Candida albicans. You can read here, they can appear in different areas of the body, oral, genital, etc. And the name is the nystatin. Nystatin. What are the side effects? You can tell me already, right? Rash. This is going to be this can produce some hepatotoxicity, nephrotoxicity, etc. All right, so that is about antifungals. At the end, we are going to make some summary of summaries, so that is going to help us to even narrow our notes. Antimalarial drugs. So we have antimalaria. Malaria is the #1 cause of death in the world. We have about 3 million deaths every year. And in United States, we have about no more than 100 cases. And mostly of these cases are coming from people coming from different areas of the planet. So they're coming with a protozoario that is called Plasmodium vivax. Plasmodium vivax is what produces the malaria. And the mosquito is not the one who transmits by itself the malaria. The mosquito is like a taxi driver where the plasmodium is going to get in and pass from the body of the mosquito into the, but the one who produces malaria is the plasmodium vivax, is not the mosquito. Okay. Okay, so we have the mosquito. When they bite, they're going to put saliva on the skin in order to, that saliva has some amount of anesthetics that produce make you unaware that somebody is taking blood from your skin. So at the time they put the saliva, is in that saliva where of the mosquito where the plasmodium is going to be living. So the saliva has the purpose to anesthetize the area, but at the time that is the saliva on the top, making a kind of anesthetic area, the mosquito is going to inoculate the proboscis, so his needle, and take blood. At that time that inoculate the needle, they are going to pass the plasmodium into the bloodstream. So this plasmodium, plasmodium vivax or plasmodium is a protozoarium that is going to be in two phases. So we have, they are going to swim into the bloodstream in between the red blood cells, and then they are going to get inside the red blood cells. So there's two phases there. And this cycle is going to be repeated every 2 or 3 days, according to the species of the plasmodium. And when what happened is this, so the plasmodium get into the bloodstream, is going to travel all over the body, then they need to multiply. So they go to the liver first, where they go, etc. But they need to multiply. They have the need to multiply, and they multiply where? Inside the red blood cells. When they multiply in the red blood cells, it's not going to multiply 2 or 3 or 4. They're going to multiply millions. And these millions are going to make they're going to occupy all the space of the red blood cell inside. So there's a moment, there is so many of them that are going to blow up the red blood cell. So it's going to just blow out the red blood cells. So, but it's not going to be one red blood cell only. It's going to be millions and millions and millions of red blood cells that are going to just rupture at the same time. That is the moment where they are going to release another substance, I'm not going to say the name, pyrogens, and they are going to produce fever. So every 2-3 days, you start to have fever, and you start to have shaking. Okay? All right, so knowing that phase, so we need to know which medication is going to destroy the plasmodium when it's traveling through the bloodstream, and which medication is going to destroy the plasmodium when the plasmodium is inside the red blood cell. Okay, so we have the chloroquine. Chloroquine is the erythrocytic phase that kill the plasmodium inside the red blood cell. Erythro means red, right? Erythrocytic city means cell. And this erythrocytic phase is where the plasmodium is start to multiply, and chloroquine is coming and is going to kill the plasmodium. Another thing that we need to remember about chloroquine is that is having an anti-inflammatory activity. This anti-inflammatory activity can be used for certain situations, for example, in rheumatoid arthritis, inflammation of the articulations. So chloroquine is going to have some effect of that. So the pain go down, the inflammation go down. It's having an anti-inflammatory action. It's not a painkiller, but the pain is going to diminish secondary to diminish the inflammatory process. Okay? We have lupus, psoriasis, we have any MS, we have any autoimmune disease. Autoimmune disease is characterized that destroy the tissues through an inflammatory process. So chloroquine, is going to can be used in this specific situation. All right, so diarrhea, anorexia, nausea, vomiting, dizziness, rash, and headache. When you see anorexia, nausea, please, vomiting, please think about gastritis, okay? So nausea, vomiting. So gastritis produce nausea, they can produce vomiting, and if you have nausea and vomiting, you are not having appetite, so that is called anorexia, okay? Anorexia. Don't think about the other anorexia that is a psychiatric problem that is going to be for long periods of time without any medication. That is called anorexia nervosa. It's different, okay? All right, so let's keep going. So the phase, erythrocytic phase, chloroquine. We have the exoerythrocytic phase, is the primaquine, the primaquine. The exo is the primaquine. The exoerythrocytic phase is when the Plasmodium vivax is traveling through the blood, and that is where the primaquine is going to destroy this sporozoite or Plasmodium vivax. This is malaria, right? So not giving in pregnancy. We cannot give in pregnancy. Okay, we don't give in pregnancy the primaquine. They have severe side effects, can be produce actually miscarriages. Okay, we have other drugs that are going to act in two phases at the same time, in the erythrocytic phase and in the exoerythrocytic phase. Who is that? Is the pyrimethamine daraprim. Daraprim is the commercial name. Daraprim is a medication who has that we are going to add the trimethoprim, that is actually an antibiotic. That is mostly used for falciparum, Plasmodium falciparum. That is the bad guys from all the malarias, falciparum Plasmodium. So this, in this case, is not why we don't use this instead of the previous one, because it's so spread out the disease in many countries that this medication is much more expensive than the previous one. So why we don't have more education and we give a more cheaper medication that can be accessed to everybody. If we have more expensive medication, it's going to reach less people. So that's why. But falciparum is, let's put it, is about 10% of all the malarias. And this is very bad. It's going to be very aggressive. It's 3-4 times more severe signs and symptoms. And that's why we use this daraprim. That is going to kill the Plasmodium in these two phases, the exoerythrocytic and the erythrocytic phase. All right, so we have medications, anti-malaria medication we can give with sulfonamides, that is a type of sulfas, tetracycline, that is an antibiotic. That sulfonamides is sulfonamides gram negative, gram positive, tetracycline gram positive, gram negative, clindamycin we mostly use for anaerobious, gram negative, and they can be used for in combination with anti-malaria. So that is going to increase the effect in the person. All right, so we have side effects: gastrointestinal nausea, vomiting, diarrhea, anorexia, abdominal pain. Okay, and the chloroquine, please, the chloroquine. The chloroquine can lead into tinnitus. Okay. Tinnitus, you know what is tinnitus? Is a ringing of the ear. That means that you're losing your hearing. Okay. All right. So when we are doing prophylaxis, prophylaxis means that I'm going to prevent to have the disease. Obviously, if I go to some area, for example, rainforest, close to the equatorial line, or in Africa, same equatorial line, where it's a lot of humidity, a lot of rain, right? And this, the eggs of the mosquito are, that's what they need, a lot of water, and water that is not moving. So in 2 weeks, they start to grow and proliferate. So that is, when you go to those areas, you need to have prophylaxis. 2 weeks before go to that area, and 4 weeks after you return from that area. So that is, remember, we don't have native malaria cases in the United States. Mostly, all of them are going to be imported from from other countries. Okay. All right. So let's keep going. All right. So that is about antivirals, antifungals. Now we are going to talk about the antihelmintics. The antihelmintics are going to be antihelmintics. We need just to remember that we have the pyrantel, the mebendazole, and the praziquantel. Okay, so just think about the names. You need to get familiar with the names. So I will say flux is praziquantel. There's to talk about that is a lot of pathology. It doesn't make sense to talk about that at this moment. I'm going to go directly to the point. So you can remember that just thinking about my parasite. So antihelmintic. Antihelmintic is antiparasites, actually anti-worms, right? My parasite. My is M is the mebendazole. P is the pyrantel, or you can think about my parasites, right? So my M and those two P's, right? Uh, you don't want to remember my PP, right? Or something like that. So it's just my double parasite or my parasite. M means my, P pyrantel, P is praziquantel. Mebendazole is MM is myelosuppression. Myelosuppression means that you suppress the production of the red bone marrow. So it's the same to say BMS. It's the same to say BMS. All right, so that is what you need to remember until meeting. Very short, very simple. Just the my parasites. Let's remember like that. My parasite, because until meeting, what is that? Anti-parasites, right? So my parasite, mebendazole, pyrantel, and praziquantel. Mebendazole, MM, myelosuppression. So you need to have you have risk for infection, risk for bleeding, risk for anemia, and we have the my parasite pyrantel that produce diarrhea, and praziquantel that can produce actually that is used for flukes. Okay, flukes we have the schistosoma manzoni, the clonorchis sinensis, fasciola hepaticus, paragominus. So we have different, that is not having sense to talk about that, but flukes are those parasites that are going to affect especially whom? The liver, flukes. They are going to establish in the liver and produce hepatitis by parasites. Remember, hepatitis is not caused by hepatitis B and C and D and E and F alone. They can be for maybe other substances. Could be for like fungus, can be by virus, can be by parasites in this case. That is a good example. All right, so my parasites is the mnemonic that we are going to use for antihelmintic, okay? So one thing that we need to remember of all the antihelmintics is that they can actually have some changes in the urine. In the urine, we have this, they are going to show like a smell as an odor as asparagus, okay? And the same odor is going to be appear on the skin. So, and some metallic taste. So that is all about what we need to remember about antihelmintic. Let's talk about antiprotozoal, and that is actually very important to remember. We have here the metronidazole. Metronidazole is going to be metallic taste, and that is going to be used it can be used antibacterial, antiprotozoal. That's why it's called antiprotozoal. We have the Pneumocystis jerovici, sorry, Pneumocystis jerovici or jerovici pneumonia. That is the Pneumocystis jerovici is actually a fungus that are going to be mostly happening in HIV patients, in AIDS patients. So that was before called the Pneumocystis carini, that is the old name for this fungus. Now it's called Pneumocystis jerovici. And for that, we are going to use the atovaquone, and we can use the pentamidine. Atovaquone and pentamidine. So HIV, okay, we have atovaquone, and pentamidine. That's all what we need to remember. The last thing is the idoquidol. Idoquidol is going to treat some diarrhea caused by parasites, and these parasites can lead into enterocolitis. It means that you have a diarrhea with blood, and that can make the perforation of the intestine. So idoquidol is going to use for amebiasis that can produce diarrhea. Giardiasis, the Giardia lamblia, giardiasis are going to be having this diarrhea with what? With bleeding. And they can be used for Trichomonas vaginalis. Trichomonas vaginalis is very itchy. They have a very foul smell and have a strong smell or fishy smell as fish. Trichomonas vaginalis has a lot of itchiness. Okay, obviously they need to be treated the couple, right? All right, so that is antiprotozoal, and dermatological drugs are going to just mention few of them that definitely we need to just remember. One of these is I'm going to go past. I'm going to mention very fast. So here we have the skin and the function of the skin. This is basic information, so you can read that. We have topical dermatology. We have different medications. Anti-inflammatories like corticoids, hydrocortisone, right? Antipruritic drugs for itching, right? So antihistaminic, for example. We are going to talk about the sulfamylone. We are going to sulfadiazine for burns. Antineoplastic, for example, we have for bacillomas, or we have some cancers of the skin. Antimicrobial, so you can see that in Safeway or somewhere, wherever you go, you can find, for example, the neomycin, the polymycin, bacitracin, that is going to be treated for bacteria that can infect the skin. Okay, so let's keep going. So what we have here is, I want you to remember about, we are going to talk about the impetigo. Impetigo is the infection of the skin with the staphylococcus and with what? With streptococcus and or streptococcus. It's very unusual to be both together. It's mostly staphylococcus or streptococcus, okay? All right, so we have the bacitracin, the neomycin, neomycin, and the combination. Remember the triple ointment, right? So we have these three together. The silver sulfadiazine, that is for burns, okay? And we are going to be the mupirocin, that is very important because it's treating what? Mupirocin going to treat MRSA. What is MRSA? MRSA is MRSA. MRSA is the methicillin. What is methicillin? Is an antibiotic. MRSA, MR, methicillin resistance, SA, Staphylococcus aureus. All right. So bacitracin, just to mention here, is going to be used for impetigo. Polymyxin, so here we have for Pseudomonas. So they come in together in mostly these triple ointments, right? This is a Pseudomona. What kind of patient we see here? Diabetic patient, immunosuppressed patient. We have a patient who has, for example, burns to second, third degree extensively. They can actually have Pseudomonas. Elderly people, right? So, and this is like, look like a foam, like a, and this, if you smell here, it smell very foul, and it's bluish and greenish. So that is the clue that is a Pseudomonas. All right, so we have the mupirocin is the intranasal form for MRSA. So mostly of the tests where are located in MRSA are going to be from swabs of the nose, and they found that there is many of the MRSA are located in that area. So that's why mupirocin is going to be topically given for intranasal for MRSA. All right, so silver or sulfadiazine is used for second and third degree. we are going to apply thin layer, thin layer, thin layer. Why? Because produce burning, pain burning, and itchy. So if you put a thick layer, it's going to last for all day, right? So the excess is going to produce more rash and more pain and more burning. So it's not needed. So we need to have a very thin layer, all right? So we have the sulfamylon, another high yield here. What I want just you to remember is that sulfamylon can be used instead of silvadine, and they can produce these side effects like burning too. So what we need to do is the apply thin layer, apply thin layer, apply thin layer. All right, so we are going to talk about anti-acne, and for that, what I want you to, I'm going to pass this because I want to high yield the topics. Is almost 2 hours, more than 2 hours, and we are going to just talk about the isotretinoin that is family of the vitamin A. It's a retinol action, retinoic acid, red skin, redness is going to produce side effect red skin, okay, red skin. What we need to remember here is that girls mostly having this acne, severe acne, they go to the doctor, and these girls are passing the puberty, and they have an hormonal imbalance. What does it mean, hormonal imbalance? Means that they have supposed to have more estrogen than testosterone, right? But they are going to have a little bit more testosterone than usual. And we need to wait until the estrogens are going to be with the time, with the age, is going to increase the amount of estrogen. So that is going to make her enter in completely balanced. But meantime, at the beginning, is going to be imbalanced. So that's why they're going to be there are other type of medication like OCP, etc. But this medication is high yield for NCLEX. Why? Because if you give the vitamin A or isotretinoin to this patient, can produce fetal malformation. What fetal malformations? Cleft palate, for example, cleft palate, cleft lip, okay, and they don't want that. So for that is required to pass what we call the eye pledge. You need to remember the eye pledge. Eye pledge is you need to have, you go to the doctor, that the girl is going to receive a booklet. Okay, you need to study that booklet. Okay, so you need to have quizzes, about 2 quizzes to see if you understood what the booklet said. In addition to that, you need to have lab tests for what? For pregnancy. 2 lab tests, no one after another. I mean, 1 week after. So they are going to wait 1 month, and then the next month are going just to be sure that you are not pregnant. And in addition, at the end, they are going to make you select a contraceptive method. So in case, because they don't want you to get pregnant, in order to prevent if you're going to receive this medication for acne. Okay, so side effects of this is the retinoic acid or the vitamin A. If they can produce dryness of the skin, so that is one of the treatment, right? Because produce dryness of the skin. If the patient has this oily appearance of the skin, that is the area, that is where the bacteria is going to grow, is going to block the sebaceous gland, and they can produce acne, infected acne. So we don't want that. So this dryness produces crusted skin, One thing, please, high yield 10 times, is the depression and suicidal ideation. So how you can assess that? You can assess if the girl is telling you, I feel lonely, or I feel sad, or I don't fit in this world, or whatever, some negative thoughts. That is going to give you a clue that probably one of the is reported that a patient who is having this medication are having suicidal thoughts, and we don't want that. Okay, so you need to report that immediately. Okay, so let's keep going. So we have again antifungal drugs like clotrimazole. We talk about that, dosages, vaginal suppository, Fluconazole. Some antivirals. So again, for the skin, just to repeat what we was talking about, aciclovir, ciclovir, penciclovir. So this is the oldest one. This is the newest one. If you know this, you know penciclovir is aciclovir. It's coming the same family. So, but this guy is new, so it's not going to be worse than this one, right? It's going to be better. So less side effects, less amount of the dose, less, for example, redness, right? So less pain, for example, basically. Okay, so that is about the this part. Oh, I want to remark about the Lindane, the K-Well, that is a shampoo. The patient is coming and telling you, you know what, this shampoo doesn't work. So I have the license all over my body and doesn't make any sense to continue. So, but you need to ask if you are using this need calm, you need to use a need calm for that. Okay, a need calm. Okay, so if they don't use the need calm, they are not using completely appropriately the Lindane. Okay, well, so use this part of the patient education. Okay, so we have the minoxidil. The minoxidil, what I want you to remember, please, open eyes, open ears, is this for hair growth, right? They can be used for male and female. And what the side effect is the minoxidil raw gain is the edemas. So you're going to gain weight. What is your assessment for gain weight, right? So you need to check the weight every day. You cannot gain 2 pounds in 2 days. You cannot gain 5 pounds in 7 days. So those are your parameters to check if the patient is gaining weight. So what does it mean if you do this gain of weight in that time? Probably they are accumulating fluid in some part of the body. Could be the abdomen, for example. It can do tachycardias, increase heart rate. So increase tachycardia, increase the heart rate can lead into tachy. Open eyes, open ears. Okay. All right. So sunscreens is going to be about you need to give it at least 30 minutes before exposure to the sun. Okay. So and that is about what I want to talk about today. I'm going to make a small summary right now. A small summary right now about what we was talking in a few seconds. Okay. Number one, we was talking about the cyclovir. What is the main thing that we need to remember? A cyclovir with antivirals is the burning when it's applied, and you need to give more in more than 1 hour if that is IV infusion. For cytomegalovirus, we have cytomegalo means bigger, huge. Is going to be the bad guy. Is the gangster. We call that ganciclovir. We have the RSV, that is the respiratory syncytial virus. We are going to use the ribavirin, right? Ribavirin. And that is going to be for nasal spray, right? Inhalatory. Why? Because the RSV mostly happen in infants, right? In infants, so very young people. So just to swallow pills, how? Right? Injections, okay. Better is to find a pathway that is the inhalatory. So that's why it's in nasal spray that inhalation is going to be given the ribavirin. Sidobudin, what is sidobudin? Is for HIV, right? So what is the main side effect of this guy is the BMS, bone marrow suppression. Can you give impregnants? Yes, of course, you can do it. To protect the mother, to not have higher levels of HIV viruses in the blood, and to decrease the risk of the transmission of HIV to the baby when the baby is going to born. So that is about 30% of the cases can be transmitted like that. So that's why we want to decrease the risk. Sidobulin. Okay? So in the long run, sidobudin and any other antivirals are going to have this side effect. What is that? Oil, okay? Oil. Oil is the osteodystrophy. Open eyes, open ears, please. What is osteodystrophy? One of the examples could be osteoporosis. hepatitis, lipodystrophy oil, osteodystrophy. I is insulin resistance, so they can have some problem with glucose. So what you need to do is a glucose test, right? And the oil L, the lipodystrophy. So in addition to all the antivirals, what else is going to you need to remember is the hepatotoxicity, nephrotoxicity, and the photosensitivity, right? Okay, so probenecid, when we are going to do probenecid? Probenecid, we are going to give to antivirals in order to decrease the risk for what? For nephrotoxicity, for nephrotoxicity. Okay, so that is about the, just remember about antivirals, okay? We're talking about antifungals, that we have the amphotericin. Please remember all the amphotericin, pneumonic, that is very important, okay? So when to stop the medication, how to assess the medication, what are our nursing interventions for all side effects of to prevent side effects or to monitor the effectiveness of the medication, okay? All right, so remember one thing, this is very important, the hypokalemia, hypokalemia in amphotericin B. Okay, so you know that the azoles, talking about the fungal, the next group is azole, the fluconazole, the voriconazole, the ketoconazole, all that. So some of them are systemic, some of them are for superficial fungal infection. Azoles mostly are affecting the activity of the warfarin. How is going to increase the dose or the effect of the warfarin, right? Another thing that we need to remember is the caspofungin. Caspofungin is another group of antifungals that is used for aspergillosis. Aspergillus. Aspergillosis is well, it's a way to say aspergillus, and aspergillosis is the disease. Aspergillus is the agent, the cause. And mostly happening in a patient who has immune suppression. We have the voriconazole. The voriconazole, this is one uniqueness about this voriconazole azole, again, is don't give to patient who has antiarrhythmics. Okay? All right, so just remember one thing in general now. The fungal infections, antifungal infections, they are going to be very short period of time of treatment, 1 or 2 days, 3 days, no. They can even be for months, okay, even a year. All right, so we have the Antihelmintics, remember, my parasites, right? My parasites, praziquantel, pirantel, mebendazole, right? My parasites. So they are going to be, for example, the pirantel is going to produce diarrhea. Praziquantel is for a flux, and what we need to remember, the mebendazole produces myelosuppression. Okay. Metronidazole is another antihelmintic that is going to be antiprotozoal. Okay. Then we have the antimalarial. The antimalaria are going to be the chloroquine, and primaquine. So one, just try to review which one is exo-erythrocytic, what the other one is erythrocytic one. And we are going to produce synergism with medications like tetracycline, for example, sulfonamides, or we are going to use clindamycin. Okay, so they are going to be used to make synergism with the antimalarial medication. Okay, so one thing I want just to add, and probably I didn't mention about in the previous, is that the malaria can produce hemolysis. So when is happening the hemolysis? Hemolysis is happening when the red blood cells are blowing up. So it's totally destroyed the red blood. Why? Because it's blowing up because there is too many of these parasites inside the red blood cells. Millions and millions that we cannot make pressure from inside, and the red blood cell is going to be totally blown up. So that is, they can lead, that is called hemolysis. And that hemolysis can block, can clot very small vessels, very small vessels. That is the complications of the disease. This complication means that at the time the red blood cells are going to block, they are going to blow up, they are going to block some vessels, and these vessels who are very sensitive to that, or very common happening, or most commonly happening, if that is the situation, if happening that way, is going to be the retina. The retina is the organ, the optic nerve, right? That is a projection, extension of the optic nerve. So that produce some clot and produce visual disturbances, even blindness. So that is something that you need to report in that case. Okay, so here we have again in the antiprotozoal now. Antiprotozoal, we need to remember the pneumocystis jirovecii. Jirovecii is especially the atavacuone that is going to treat this pneumocystis jirovecii. Mostly happening, this is opportunistic infection, mostly in HIV. Another thing we need to remember is the dark urine that lead the antiprotozoal. So that is actually one of the things I want you to just keep in mind. Okay, about the skin, the Kewal shampoo, the retinoic acid, so the eye plate, this is very important to remember. The sulfadiazine, the sulfamylone. So you know that they are going to give a very thin layer application because produce burning of the skin. What is a medication for example, impetigo, for what we are going to use? And the MRSA. MRSA is the intranasal. Okay, so that is about, I would like to talk more about this, but definitely the time is over. It's it's already more than 2 hours. I think 9:30. 10:30, so almost 2 hours. So I will, if they have any questions, please, I'm going to just finish right now. And I want to thank you everybody for coming. We have 8 students, and I really appreciate your time and your effort. All right, if there is any question, yes, please let me know. Just a moment, I'm going to.